So if I go off topic, you'll know why. Alright, so our next speaker is, this is going to challenge me, Jason Threthowen, right? Done. CEO of Headspace, an amazing organisation that does some really, really good work. Jason commenced as CEO for Headspace in February 2017. Jason has spent the bulk of his career in the health sector, where he's been driven by a passion to improve mental health services and access for all Australians. Jason is involved in many national mental health system networks and is currently a company director with both Barwon Health and Professionals with Alzheimer's. Headspace Youth Early Psychosis Program aims to help practitioners provide intervention and specialist services to young people who are experiencing or at risk of psychosis. Welcoming Jason.
Thanks very much, Mitch, for that kind introduction. So first of all, I'd just like to acknowledge the Gadigal people and pay respects to elders past and present. I also want to acknowledge any Aboriginal and Torres Strait Islander people with us here today. I'd like to acknowledge people in the room with lived experience, either personally or as a carer, family member. I think that probably makes us all really in many ways. Sorry. Click next slide. You can do your job. Oh, there we go. No worries. See, we're a team, Mitch. That's good. I'd like to acknowledge everyone with lived experience in the room today. Sorry. I won't touch that again. Also want to say thanks, Kathy, for inviting me today, and for OneDoor for hosting this very important symposium. And I trust and I know already from the session this morning that people have got a great deal out of it, some good conversation, and again a wonderful opportunity just even informally to meet people over a cup of tea and just talk about mental health. And importantly, I think with mental health is that we just don't talk all about what's wrong, we've got to talk a little bit about what's working and what we need to harness. And I know that in my own organisation, particularly with recent narratives, it's hard to avoid the word suicide whenever you talk about an organisation like Headspace or Youth Mental Health. And it was one of the Aboriginal young ladies who work in my office come to see me and said, I joined Headspace because it provides me hope. It provides optimism. It brings youthfulness into discussions that need young people's voices. I didn't join a suicide prevention agency where all I'll do is hear and talk about suicide all day. And I guess for me that is the balance that we're all in. In my view, it's a balance between realism and optimism. The reality is it's tough. People might see the brand of Headspace and think, oh, they're just a bunch of shiny people running around, apparently getting lots of money from politicians, but I'll talk about that later. And then there's the reality. The reality is it's actually hard, even if you run a Headspace centre like OneDoor here doing Campbelltown. It's actually not easy. It's tough work. But people work there because it creates a culture of hope and optimism, and that's the place you want to be if you want to be helping people, particularly from an early age, particularly for those young people who are seeking help at an early stage in life. For those who are experiencing a relationship breakdown for the very first time, for those who have feelings of anxiety and depression, for those who have lost someone close to them and they're not sure where to go next. It may be around I don't know where I want to be in life. It might be work and study related. It might be that I've tried first year uni, I was pressured into doing this course that mum and dad wanted me to do, but I don't want to do it. What do I do now? I'm lost. I don't come in necessarily with a brand on my head saying, I'm mild, I'm moderate, I'm complex, I'm severe. Boy, I think we all go up and down those words every day, don't we? You know, who has the same badge on their head? I don't like those terminology, even though I know it's there for a reason. If people come into our organisation, or indeed the organisations that run Headspace centres, they want to be listened to, they do not want to be judged, they want to be understood, they don't want to be told. And it's that I've learnt in my own career, where my first 10 years of my career growing up, or let's just say after I've grown up in regional Victoria, I now live in Geelong. My first 5 years was in a hospital in Ballarat, the next 5 years was a hospital in Geelong. And the health system was all about hospitals for me. My lens was people come in, we provide the best possible care, and we move them on to somewhere else. People come into the emergency department, we look at the figures, we look at the categories, we look at the wait times, and people have moved on. We might occasionally talk about a GP referral. We wouldn't dare probably talk about discharging them back to a person who was a carer or a family member. We might send a discharge summary back to a GP who may or may not see that patient after an episode in hospital, an emergency department, outpatient appointment, or what have you. When I stepped out of the hospital system, because you're conditioned by what you see and what you feel and what you do every day. And when I stepped out into a small organisation, which back then was called a division of general practice, trying to work with the cottage industry of general practice, bringing them together for education events and talking about how the system is a little bit fragmented in primary care. But we started to talk, and I started to learn a lot about mental health, even though I supported in my sort of, I'll call it administrative roles, to be sort of simple around that. A navigator, a facilitator, an engager, an in-betweener between clinician, between finance, between technology, between occasionally you get to talk to a patient, which is pretty cool, let alone a carer or a family member, when you hear about what really goes on. And when I stepped out into that primary care environment, I started to learn, geez, actually, there's a whole system of care, or not, in our community, and this is me just being a local in Geelong, about what's available to people when they really need it. Where are the services closest to their homes? And the best lens for that was people who were living with a mental health condition, a series of complexities, whether it be with their physical health. We live in a multi-morbid environment. We just don't walk around with diabetes. We have diabetes and other. And people with mental health conditions also have physical health issues as well, which only one specialist and the next one after that is also a challenge to navigate the system. But through the eyes of mental health, and just through that on its own, was something that taught me a great deal. And one of the first responsibilities that I had in 2007 as my first CEO role was to implement this thing called Headspace. I saw it as a green flashy thing. We already do this in our community. What do we need this for? Oh, hang on, I've got to sign a contract. I better make sure I'm out here and we better make the best of it. It was one of the first 10 implemented in Australia. Wow, what did I learn from that experience? One was you've got to bring people along with you. You've got to stop, listen, understand what's going on in the community, understand the depth and breadth of the need and the challenge. I know at the moment in Australia we're sort of a little bit overdone with planning, needs assessments, find out what's wrong. Most of us are actually interested in what are we doing. So for me it was actually a combination of getting to understand the depth and breadth of mental health challenges, the AOD challenges, the disengagement from school of young people, youth unemployment, particularly in high areas of social disadvantage in my community. And from there, actually, it took a team effort. And what Headspace taught me was not only is it important to be mindful of those who you're trying to support, but also be mindful of those who are supporting those who you're trying to help directly. And by that I mean, is that Headspace taught me that it's a platform for hope, it's a platform for engagement. It's not the be-all and end-all, absolutely not. It's useless on its own. It's pathetic on its own, actually. But one thing it can do is it can bring people together for a common conversation, for a common strategy, to link in with schools, with community agencies, with the mental health services, and be able to provide care as much as they possibly can within the limitations that we all know that the mental health system has. And there are many. We effectively work in a very discriminatory environment, where sessions are capped, where you're told you can't come back for another X number of months until things work around. In Headspace, I've entered an organisation that runs Headspace in regional New South Wales. They've been running it for 11 years and they've had 11 one-year contracts. You wouldn't run a school, you wouldn't run a hospital like that, but we run our mental health services. How unfair can that be? What uncertainty does that create? And indeed, what limitations does that put on people who are seeking help, where they expect continuity of service? If you talk to an Aboriginal and Torres Strait Islander young person, they don't sign up to the green flashy brand. They sign up to a relationship with an individual. And that's the engagement. But if that individual's on that sort of one-year contract, it's May, we haven't found out yet if we've been funded yet from July 1, that's a little bit difficult, and that people do move on to more secure employment. Thankfully, irrespective of what happens today, Headspace itself has certainty with multiple year contracts for anyone who works in that system. And so it should be for all other people who are working in the mental health system that we have, and perhaps we all aspire for it to be as well. The other thing I'd just like to mention in relation to the context around today is that Mitch mentioned in his introduction, I'm on a board, so an LHD board, a hospital network board, and there's no shortage of information about demand, and there's red lights, there's green lights, there's numbers. I don't see in any of the reports that I get as a director of the unmet need. I actually don't see the numbers of people who have self-harmed, the number of people who have attempted suicide, and maybe later on, 18 months down the track, I might find out about how many people have completed suicide in my community. There's very little measurement around mental health, which is any wonder when it's the 14% of the burden of disease, it's only 7% of the funding. Because we're unable to tell our story as much as we would like to. We measure the success of our systems based on those who access it. Where do we measure for those who don't access? How do we count? So it's one of our challenges, is to be mindful of who we need to reach, what is the unmet need, but also celebrate the diversity of people who do access services. So for instance, I can give you numbers like Headspace, since it started 12 years ago, 500,000 individual young people between the ages of 12 to 25 have sought help. I can tell you that for those who present with anxiety and depression symptoms, 62% of them improve as a result of their engagement with Headspace. I can say that around 45% when they engage with Headspace, they have high to very high levels of psychological distress, compared to a population of 9%, where our most recent figures show that those between the ages of 12 to 25, 32% of young people have high to very high levels of psychological distress. But it's not only just about reducing that particular outcome measure, it's also, for me, I know we talk about mental health a lot, but actually what I'm driven by is actually, has someone improved their life? Have they been given a set of tools, some ideas, some techniques on how to handle those symptoms should they emerge again? So it's as much about a functional outcome as it is about a mental health outcome. So I'm really interested, for instance, how do we know when we get there? How do we know that when we have so many people, or a percentage of young people who are disengaging from school, so the educational attainment rates, youth unemployment versus youth participation rates, they're all figures. So when I looked around, when I started at Headspace, I got the bit about importance of looking at the own organisation and the access points and outcomes for our own service. But if I go back to the point that Headspace on its own is useless, well, what are we doing as a community to know how we're going? How do we know when we get there when we're doing well? What's the population measures? And there are very few. There are very few. So one of the things that we're doing off our own bat is to actually come up with experts. I'm not the expert, you said that earlier, didn't you, Kathy? We're not the experts, we're just trying to get the right people in to make the best possible discussions, to make the best possible decisions. But one of the things we want to have in the next 12 months is the creation of a national report card around youth mental health. And it's not just going to be simply around access measures. So what I mean by that is, what are the key measures we should be measuring as a country? A bit like closing the gap report. I think it was Prime Minister Rudd introduced. How do we know when we get there? It'll be some time, but we need to be able to measure it in terms of our effectiveness as a community in supporting the mental health and wellbeing of young people. The thing with Headspace is that it's 77% of young people in our recent population survey recognised Headspace as a youth mental health organisation. So 3/4 of young people in Australia recognised it. It was actually more recognised by those with living in very high levels of psychological distress. In other words, if you are feeling it, then you know about it a lot more. And the stigma is still real, despite what people may say. The stigma is still real. It's much better than it was when many of us in this room were growing up. Suck it up, move on, she'll be right. In fact, if there was a service there, I was still afraid to still walk through it. So at least we've softened the entry, but guess what's happened now, 10 years on, as a part of the evolution of Headspace? all of a sudden we might be failing young people. There's too many young people queuing up at our front door. You were meant to be there for mild to moderate, but what about the severe and more complex conditions? How are we managing that? Are we failing young people? We have wait times for people who are accessing one of the 110 services across Australia. Not something that was actually meant to be. Wait times are for hospitals, for outpatient departments, for emergency departments. But guess what? There's a capacity, there's a supply. A lot of that comes down to certainty around workforce and contracts and all those sorts of administrative things, but it actually does make a significant difference. So part of the narrative and part of the realism that we're working with at the moment is that, you know what, yeah, you bet. Australia is failing young people, and it's failing people of all ages, mind you, when it comes to being a system rather than just a series of fragmented providers who are trying to work with each other. Despite best intentions, it's pretty tough once you become a carer, or once you become a client or a patient, however they wish to term you. That's when you find out how good the system is or isn't for you. And it's patchy. We know it works really well. We know it doesn't work so well for many people. So part of the narrative now for Headspace going forward is that we absolutely agree that more needs to be done to work with people with more severe and complex mental health challenges. But again, that's through partnership. It has to be through that platform of hope. It has to be through that platform of relationships at a local community level. And it's something that obviously requires investment. And for all the investment that both Labor and Liberal have been announcing over the last 6 weeks or so, the figures are big, the figures are over a long period of time, and a country is a very diverse area. So it's great to see areas like Katoomba getting announced as having a Headspace centre and some outreach services into Hawkesbury, or to some more investment into rural and regional areas. That tends to be another Headspace centre in another community. But again, off the back of that, we need to also look at what's the future investments going to be for people of all ages, but in my case for people with, for young people, about where do they go, should they need longer term care and support. So the system is under pressure, that's the reality that I'm in. But if we only look down and say we're out and about, we're down and out, then we won't go anywhere. We won't go anywhere where young people want to take us. People talk about the brand of Headspace and the recognition I said before about people understand it. Actually, it's buzzing out there that young people are going towards, they're navigating towards it. And we're catching up, we're actually behind. The brand and substance gap is big. But I'd much prefer to work towards something that's hopeful and optimistic. Much prefer that. And that's what excites me, and that's what excites our organisation, but most importantly, it excites local communities who, all too often I've seen, have been allocated some funding at the Headspace, about $800,000 a year or whatever it may well be, off the back of tragedy. So I want to acknowledge not only organisations like One Door, who are one of 70 local organisations who run Headspace across Australia. 70 organisations running 110 Headspace services, commissioned by 31 primary health networks as the new entrant. That's the environment that we're in, that's the policy environment. I'm big on localism, I'm big on regionalism, but I want to take away some complexity where we can.
Sorry, Jason, could you just say that again? There's 70 organisations running 110 Headspaces across Australia?
That's correct. So Headspace itself does not run the actual organisation. So the changes with the Mental Health Commission back in September 14 and the changes that came through in July 1, 15 introduced the PHNs clearly in their role of commissioners. So it's like a franchise model. And people talk about variability of service. What our job has been though, unlike others, has been that we've actually we do model integrity checks. So we actually evaluate local Headspace centres' adoption of the model itself. And there was a fair range of diversity in the model as a result of drift in a couple of years of uncertainty and a great deal of change. So actually one of the important things, if you are a Headspace, are you really a Headspace? Do you have examples? Do you have evidence of youth engagement, family and friends advisory? Do you have examples of working with consortiums of local agencies and obviously adhering to models of care as part of the clinical components as well. So that's something that we obviously do as a result of that. So it brings me really to the, the fact that we talk a lot about reform, we talk about change. Headspace is an organisation and a network now that has been through an enormous amount of change. It's been the recipient of the Mental Health Commission's review in 2014 and adopted in September or November, I think it was, in 2015, where actually our organisation wasn't sure where it was going, but it's now got a very optimistic future, a very bright future, but one that we have to build on, one that we're actually not afraid of criticism. We're actually, in fact, it's complaints are gifts, the young people themselves, and family and friends when we hear their experiences. Our board met in Bankstown during the week, and we heard it from young people and from the clinicians there around working with communities from non-English speaking background and those challenges there. That's my 20 minutes. So I better get going. So I want to just say a message just in the interest of time. For everyone who, for your motivations and your passions that you bring to the mental health system, is to be kind to one another. Firstly, look for the good in us all. Look for the good in the experiences and learn from those where perhaps it actually hasn't worked. Don't look down on ourselves, look up, to give hope, to give optimism, but never get carried away by the realism that exists in local communities as well. And I'll take what Tim said before, is about providing an environment that enables those that need a voice, that they get a voice. I couldn't agree more. In our own little world, we will have young people on our board, national advisory groups involved in any development that we have, they will be involved. And likewise at our local Headspace Centre, in some cases up to 35 young people will be advising, critiquing, and increasingly now with family and friends, their role in that as well. So I want to say thank you for the opportunity, Kathy. Thank you, One Door, for the opportunity to present to you today. Maybe a little around the tree a little bit, but my message in the end is that we're in a privileged position, I know that. But gee, we've got a long way to go. And what I need to know though, how do I know when I get there? And we're still to work that one through. Thanks very much, everyone.
Thanks, Jason. Amazing to hear the humility and groundedness of an organisation that is so fortunate when it comes to funding and outreach, but yet still acknowledges we have a long way to go. As a fellow charity member, I'm very envious of that funding. I would like some. So if you have a spare few dollars, check it out.
I'll tell you what our challenge is for the next election is that we don't just celebrate millions in mental health. When I look at the budget, you see billions going everywhere.
Yeah.
So we've got to move from M to B. Yeah. That's our target. That's our target.
Yeah. Very cool. Now, amazing work by Headspace as an organisation that I think we can all attest to. So thank you, Jason, very much for your words. Next, we're hearing from Dr. Justin Scanlon from the University of Sydney. He's a senior lecturer and course co-director of the Bachelor of Applied Sciences. Are we still good at this? Yeah? Okay. Occupational therapy at Faculty of Health Sciences. He's an occupational therapist with a clinical background in mental health practice. His focus mainly is on people living with quite serious mental illness and living a life of meaningful activities with a focus on overcoming cognitive barriers to performance. Justin's current research project is integrating cognitive adaptation training, CAT, into routine practice in government and community managed mental health services, a knowledge translation pilot. Thank you very much. Click on that hyperlink.
Okay. So thanks everybody for coming along today. A very exciting suite of presentations, and I hope that you enjoy this one. I'm talking today about integrating cognitive adaptation training, or CAT, into routine practice in mental health services. So to begin, I'll acknowledge a few people. Firstly, I'd like to acknowledge the traditional owners of the land we meet on, the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging, as well as to any Aboriginal or Torres Strait Islander people in the room today. I'd also like to pay great acknowledgement to the lived experience. The exciting thing about being in this room today is that the vast majority of people here do bring their own lived experience of mental illness and recovery, or caring for others on that journey. I'd also like to acknowledge Wandle Mental Health, both for inviting me here and letting me speak, but also for giving me some cash to do this research. Very, very, very helpful. I'd also like to acknowledge my research team members, Dr. Nicola Hancock, Professor Lindy Clemson, Associate Professor Lee Fei Low, and Dr. Anne Honey from the University of Sydney, Megan Still from the Sydney Local Health District, and Jessica Heikkinen from Nepean Blue Mountains Local Health District. I'd also like to acknowledge my partner organisations, Sydney Local Health Districts and Nepean Blue Mountains, as well as the CAP developers, Professor Dawn Belligan and Dr. Natalie Maples from UT Health in San Antonio in the US. They've been very generous in providing me training and also allowing me to use their resources, some of which are in this presentation. So the question is, why CAT? Just so that we can use nice GIFs? Maybe that one's gone a bit shoddy. No, cat GIFs are nice, but I'm not a cat person either, actually. The reason why cat, as an occupational therapist, my life's work is really committed to supporting people to live the life that they want and to do the things that they want to do. And that's what drives me, and that's what I'm really passionate about. But sometimes when I'm working with people who are living with a mental illness, there's razor wire that blocks that. And that razor wire is because of a bunch of things. Because of stigma, it's because of disrupted opportunities, it's because of poverty, and it's because of lack of social connection, amongst a huge amount of other things. But there's another big thing in this mix, and that's cognitive difficulties. The difficulty is actually getting things together, being able to plan and problem solve, to do the things that you want to do can be a big barrier for people. We know from a lot of research evidence that about 30% of difficulties with daily functioning can be associated with cognitive difficulties. So this is a big mountain to try and climb. So what the CAT approach does, there's two approaches to working with cognitive difficulties. One is a remediation approach, where you try to reduce or alter or fix the thing. And this is the case with approaches like cognitive remediation training, where people try to improve their cognitive skills by doing computer games and various different other things. And so that's trying to reduce the level of cognitive difficulty with the hope that that will translate into improved daily life. The other approach is compensatory approaches, which is where you say, okay, the difficulties are what they are. Let's find a way of actually working around them. And so if we extend the razor wire analogy, remediation approaches try to cut down or bust through the razor wire, whereas compensatory approaches try to go around or over the razor wire. And so the CAT approach takes a compensatory approach. It says, let's focus on what people actually want to do, and let's find ways of assisting them in everyday life to actually do those things. If along the way cognition improves, that's great. But what we're really focused on in CAT is actually supporting people to do more things that they want to do. And at the end of the day, my perception is that that's what people actually want. They don't want to score better on a neuropsych test. They want to be able to get out and meet with their friends. They want to be able to go back to work. They want to be able to keep their houses tidy if that's important to them. And so that's what I think the real benefit of this approach is. So the CAT approach integrates the use of environmental modifications or supports to enhance, not enhanced, independence in valued or necessary daily activities. And so I highlighted valued or necessary there for a couple of reasons. Valued activities, pretty straightforward to all of us. We want to do the things that we want to do. We value them. Sometimes with necessary, it's like, I always use the analogy of doing the washing up or doing the vacuuming. It's something that in my experience does need to be done at least once every 6 months. So sometimes they're necessary. Not every day though, really. And so what CAT does is it tries to figure out a best fit approach to how we can change things to support people to do the things that they want to do more independently. And CAT does this by setting up a little bit of a matrix that looks at 2 different factors. The first factor is the amount of cognitive difficulties, which is troublesome to me in a little bit, in that it is quite labelling. But you'll see that it's not, when you get down to the actual implementation of this, it's not so much labelling. It can be maybe a little bit helpful. So it just says more difficulties or fewer difficulties in terms of cognition. And then it looks at what's called an activity approach or a behavioural approach. And it looks at, do people have most difficulties getting started in activities? Do they have difficulties focusing on the right things when they're doing activities? Or do they experience a mix of both? And when that's the case, the CAT approach supports us to think about the best fit for the types of supports we can implement. So if somebody has difficulties getting started in activities, then it's about implementing reminders and prompts, developing routines, maybe having instructions for different things. Difficulties focusing on the right things. Sometimes it's about simplifying the environment, taking away some of the distractions, decluttering, helping people organise their environments in a way that will help them focus on the things that they need to focus on. And when somebody has a mix of both, we need to use a mix of both of those things to support that person's better functioning. So now I'm going to give a few examples of some of the changes that CAT can deliver. Now I will note to begin with that these examples will seem fairly basic and focused on what might seem necessary activities but not valued activities. And I will note that one of the challenges in this space is being able to take photos of valued activities. It's pretty hard to take a picture of somebody before and after being socially engaged. So these ones are practical daily kind of things because they're easy to take pictures of essentially, but CAT can address both. So this is an example of different intervention approaches that can support people being able to organise themselves to get dressed and wear clothes appropriate for the day or the time of year. And so the first picture on your left left, is an example of if somebody has difficulties getting started. So this takes their clothes out of the cupboard, because sometimes if they're in the cupboard, you will attend to the old clothes that are on the bed rather than the new clothes that are washed in the cupboard because you don't see them. So this keeps it out in view and provides a visual prompt for people. What we do in this circumstance as well is make sure that there's a laundry basket near where the person takes off their clothes, so that the clothes aren't there to prompt them to put them back on the next day. So the clean clothes are there, the dirty clothes are out of the way. Then there's the middle picture is about organising things to reduce distraction. So this one, the person sets up and picks what they'd like tomorrow Monday, what they'd like tomorrow Tuesday, and they're all put in label boxes. And similarly, in the third picture, same thing, but then those items are again in view, so it provides a prompt as well. With this circumstance, we may also have a reminder or an alarm or something in someone's daily routine that will remind them time to get up, have a shower, and get dressed. Other kind of reminders around bright visual cues, often in the language of the person themselves. So we like to use somebody's own message to themselves to remind them to engage in different activities. And then when it comes to people who have difficulties focusing on the right things, this is just an example of one of the CAT interventions that they did in the US, where this was actually somebody's kitchen table with all of those different medications, some of them old, some of them not needed anymore, and really simplifying that so that they could actually focus on which ones they needed to take. And this was in the case of somebody who did desire to be organised with their medication, didn't have a problem with taking their medication, but just found it difficult to know which ones to take. And if you think about all of those different containers, it would be incredibly difficult to find the right ones to take. And then other examples. Again, this is a medication-related one, and it's about simplifying the activity. So you've got water bottles with the medication and a reminder. This clock is a speaking reminder clock, and so the person records their own message to themselves, saying, it's really, time to take your medication. Remember that it's important to take your medication because, and the person relates their own valuing of the importance of medication, rather than somebody else saying, you should take your medication because otherwise you'll get sick. It's a person's message to themselves. And then there's also a number of supports that will help scheduling and organisation. So that's just a few quite basic examples of the way CAT can be implemented. One of the really good things about it though is that the principles can be applied to larger, actually more important aspects of life as well. Colleagues in Victoria have looked at using CAT for young people in early psychosis services returning to work. So it's got a lot of applicability across a lot of different areas of life. So it's implemented in people's natural environments. Obviously you do your daily life in your own environment, and so we need to do CAT there. It fits very well within a typical kind of support structure where people are doing home visits, and it structures around a review, explore and implement approach. And the intention is to gradually fade out support so the person takes more and more responsibility, and this just becomes part of their everyday life. There's lots of strong evidence for CAT to say that it improves community functioning, improves people's well-being, could improve people's ability to manage symptoms. There's an educational component of it as well, and reduced hospitalizations, which I think everybody wants. The challenge though with, this is a translation project, because a lot of times getting research evidence into routine practice is quite challenging and takes a really long time. And so what we're focused on in this project is actually working with partner organisations to embed CAT into daily practice. So in the context of this project, we look at exploring the perceived barriers to implementation and the perceived benefits of implementing CAT, training to identify key staff and provide training to those individuals, supporting implementation, and looking at barriers and ways of getting around those barriers, and then investigate their clinicians and mental health workers' perceptions of usefulness of CAT, outcomes achieved by consumers, and strategies to really support ongoing implementation and plans for sustainability. So far, we've engaged with 2 government mental health services, and we, as part of the project, will engage with 2 community managed organisations as well. NDIS changes have challenged us in this space. A lot of CMOs are, it's difficult to look forward when you don't know that you're going to be there next week. So it has been challenging to actually engage with CMOs at this point. If anybody in the room is interested in talking more and thinking about your organisation, that would be fantastic, and I'm really open to that. And our participants are service managers, mental health workers, and consumers. And so we will roll this out and really hope that it becomes one of the tools that everybody accessing mental health services will be able to be supported to work with this kind of approach, and also be a tool in the toolkit of every mental health worker in New South Wales is my vision. So thank you very much. There's not questions now, I don't think, but if you want more information, I'm here, and there are my contact details as well. So thank you very much.
Thank you, Justin. A little bit of organisation goes a long way, that's for sure. I'd like to introduce Emma Cartland, our next consumer speaker. Emma Cartland has worked with One Door for over 15 years, supporting a number of programs. Emma was diagnosed with major depression in her last year of high school and underwent a number of treatments, including ECT. She believes it was this, along with meaningful employment and lifestyle approaches, that has helped her to live well today. Emma continues treatment and management of her illness. In addition to her role at One Door, Emma also works in school administration and is dedicated to horses and riding competitions. Nice to see you, Emma.
Sorry.
Hashtag job failed from me.
One Door Mental Health for inviting me to come and speak today. And secondly, I'd like to thank everybody here for listening to my story. Now, I'm going to be doing something a bit different from everyone else so far. The topic for me is going to be me. I'm going to talk to you about the journey from my original diagnosis of a major depressive disorder through to my current management of that major depression. Now, I say management because I still am treated and have major depression. However, I no longer see that as a problem or something that's going to stop me from doing what I'm doing. So firstly, when I was in year 12 doing my HSC, I was originally diagnosed with major depression. I never finished my HSC. I actually got my HSC on illness appeal. I only did 1.5 exams, and then shortly afterwards was hospitalised due to a suicide attempt. When I first went into hospital, from what I remember, it was really mainly a time of confusion And I didn't want plans for the future or what was going to happen in even 2 weeks' time. At that stage, I didn't even know if I was going to make it to the end of the day. So what I first wanted was just a safe place to be. At that stage, I felt like my world had imploded on me. I wasn't going to get my HSC. I wasn't going to have a future. I just wanted somewhere to be safe. And I didn't want people to give me advice. I didn't want people to tell me how I should do things. I just wanted people to listen. And sometimes what I said didn't necessarily make sense, but I didn't want to be told it didn't make sense. I didn't want to be told it wasn't going to work. Just the fact of actually talking to someone and saying something sometimes made things make a little bit more sense to me, or at least they got them out of my head. They got them out of my head to somewhere else because there was so much going on in my head, there wasn't a lot of space in there. So then I was actually in and out of hospital for, I think, about 5 or 6 years, trying many different medications, none of which worked. Alternately, they'd work for a short while, and then after that, 6 weeks later, I'd be back in hospital again. The final treatment that really worked was actually electroconvulsive therapy. Now, you know, when they first mentioned that, I was terrified. I'd only seen it on television. Didn't look very nice there. But it was actually the most successful treatment I had, and to be honest, if I was ever going to be admitted back into hospital today, I want to have the ECT. It was very well explained to me by the doctors. I had to see 2 doctors to check that I was actually safe to go through with the procedure and that it was actually warranted that that was going to be the best option. They explained it to my parents, and then before I had my first session, again I saw the doctor. That was a very supportive environment, and really the only side effect I had straight afterwards was a little bit of a headache, which had gone by the end of the day. The other thing I did get was some short-term memory loss, but I find now one of the really interesting things is that the ECT probably started about 10 years ago, or no, probably about 15 years ago actually. And now I find if I sit down with some photo albums with my mum and go through those photo albums, those memories are coming back. So the long-term and the good memories have never gone away. Sometimes I needed to recoup them and have some reminder that that was all. And the other thing I also had was actually outpatient ECT. So there were times where I was decided that I was well enough to leave hospital, and I'd go in it was an early start in the morning, so I had to be there at about 4:30, but go in early in the morning and have ECT, and then in the afternoon I'd go into my mum's work in her school library and help her with the kids. So it's really not something that is extremely debilitating, painful or scary. I'm not saying it would work for everyone, but for me it was really the thing that made the difference. The other thing that made the difference with me was the support network I had around me. They were my 3 most important people to me were my sister, my mother and my father. Obviously my friends were also very important, and the thing which made the support network so good for me was that they were there, but they didn't tell me what to do. So they'd let me make mistakes. And for me, I think that was one of the most important things. Because when I was getting better, one of the things I was most scared about was if I stepped out of my comfort zone and did something new, what if I made a mistake and it all fell apart? I couldn't do it. So the fact that I was allowed to make mistakes, but then supported to put things back together again. Obviously not any huge, like I was still kept safe, but little mistakes, I was allowed to make them. And then it wouldn't be, you've made a mistake, this is how you get it better. But I would get supported to figure out my own plan and my own life. And that made a really big difference. It encouraged me to follow the path I wanted to do, and it gave me strength to keep going when things weren't easy. The other thing my family did, which was really important, was to believe in me. There were times when I was in hospital, I didn't believe in myself. I didn't believe in anything. And the fact that I had people there who'd known me all my life and said, we know what you can do. We know you can get through this. That made the difference. They didn't tell me how to get through it. All they said was, we are there for you and we know you can. And that was it. Another very important person I had in my life was my riding instructor, Gisela. Now, I've been riding now for, I think, about 30 years. And the thing about my riding coach was, there were times like, riding was always a thing for me. So if I said to Mum, I don't want to go out and have a riding lesson, she'd immediately go, something's wrong. So then, or same with my coach. So then I'd go out with my coach, and I wouldn't necessarily have a riding lesson in how to do dressage movements. Sometimes it would be, let's go out and have some fun on the horse. So my coach as well would say, it doesn't always have to be about improving yourself, improving your skills. Sometimes it's just about the relationships. If I wanted to do dressage movements, we do them. But if I wasn't up to it, then we just have fun. So and the other thing is, I was for many years on the disability support pension. I now work full time and I'm off the disability support pension. But that decision also came from me. I was supported into employment, just as I would also like to say, my way I came to One Door when it was a schizophrenia fellowship was also actually, I think, from a stepped placement. So I was supported into One Door, which started my employment. That started me on the road. It probably must have taken me about 18, 19 years to go from no employment to part-time employment to full employment of the disability support pension. But in the end, I decided it was what I wanted to do, and that's what made me do it. And the way I see things today, as I said, I'm still under treatment, on medication for major depression. But I feel that I have control of that major depression. Now, I don't know what's going to happen 5 days from now. I don't know what's going to happen 2 years from now. I don't know what the future holds at all. But what I do know is, because of things that happened while I had the major depression and the strength that my family and friends, my carers, helped me build through that time, I feel now that if there is a setback, I can face it. I can cope with that setback with my family. I don't have to feel like I failed. I don't have to feel embarrassed. And I understand now that everyone has setbacks. When I was first in hospital, any mistake I thought was my fault. I'd done everything wrong and I was a failure. Now I realise mistakes are human. You're allowed to make them, and my family helped me realise that. They said, you're allowed to make mistakes. Everyone makes mistakes. Everyone has difficulty in their life, and sometimes everyone just needs a safe place to go back to just relax and rest. And that's important, and there's nothing wrong with that. It took me a long time to learn that, but that was probably the most valuable lesson I've learned. And it's something I'll keep in my head for the rest of my life. Because, there's nothing wrong with asking for help. Now, the things I've mentioned about what happened during my treatment, I don't think I really knew they were happening during my treatment because, my family didn't say, okay, now I'm going to sit down and listen to you about, the bad, what's happening or anything. It was just things they did. And sometimes it's the things that people don't say that make the most difference. And, and I probably at the time was not very appreciative of it at times. In fact, I was probably really difficult and grumpy and didn't accept their help because I was at times in acute stages of major depression. But that didn't mean it hasn't made a difference to the rest of my life. And my family, my carers, they're the ones who've made me who I am today. My family have shown me the way. I probably wouldn't even be here today without my family. They were the ones who knew when things were difficult. They worked with the doctors, but they were the ones who lived with me. They were the ones who listened to me. They were the ones who knew everything about me. And they were the ones who would stand by me for the rest of my life, even if something else goes wrong. And that, you know, I am where I am today because of my family as carers. And I can't say the importance of carers for me is just, it's made me who I am today and the person I am today. Thank you.
Unbelievable. I mean, it's stories like that is, I don't know, it's why I get up in the morning, it's what it's all about, this life thing. So, Emma, thank you for sharing that. It touched me personally, and my biggest takeout was your resilience, your ability to just stay with it, let the process unfold. And the only way you're able to do that is the people around you just holding space, right? Not forcing you in any certain way, just holding the weight, and eventually it takes its course. Amazing. Dr. Anne Honey is next, University of Sydney. Dr. Anne Honey is a senior lecturer at the faculty and the faculty director of OT, occupational therapy, at the Faculty of Health Sciences at USyd. She has a professional background in mental health, occupational therapy, and her research has focused on understanding the experiences and perspectives of people who live with mental illness and their families to improve the support provided. In particular, Anne's current research project is called Stella, supporting the translation into everyday life of lived experience research, which I think she's going to focus on today.
Yes, thank you, and it is a little bit of a mouth, I admit.
And I'm not going to screw up my job again, so I'm going to... Are you up? We're off and running. How good's that?
I'm good. The first thing I have to do is apologise because I'm not actually doing this presentation all by myself. I'm doing it with some colleagues and students from UTS, Angus and Bailey, and you'll be hearing from them shortly. So I've just got my stopwatch there to remind me so I give them enough time and don't talk for too long. So I'm talking to you about Stella, which stands for Supporting the Translation into Everyday Life of Lived Experience Research. It's a collaborative project between lived experience researchers and researchers without lived experience from a whole lot of different organisations, as you can see. And of course funded very gratefully, thank you very much to Wondle. So lived experience research in mental health is research that both illuminates the perspectives of people with lived experience and is also done by people with lived experience of mental health challenges. So that can be either independently or within collaborative research teams that also include people without lived experience. And of course that's really important because it means that the research that's being done is much more likely to be relevant to people and also, whoa, I wasn't even touching that. So it's magical. Yes, and so of course it'll also be done in a way that's more likely to be meaningful to people and also respectful of people. So the Stella research team think that lived experience research has the potential to be of direct value and benefit to consumers as they're going about their daily life and their recovery journeys. But that's never really been looked at before. But of course, there's a good deal of research that shows that learning from the lived experience of other people is important. So for example, learning wisdom through what other people have experienced and also just of course seeing people who are going well on their recovery journeys. Individual stories is a really good way for that to happen and that's really important. But lived experience research is another way which can take a whole bunch of different stories and bring it together and give, I guess, a bigger picture or an overview of an issue for people. So we think that lived experience has the potential to be a really good resource for recovery. our team got together at a mental health leadership exchange match, which focused on consumer-led and collaborative research. And one of the peer workers who was there was saying to us, wow, I didn't even really know that this thing called lived experience research actually existed. And so that really made us think about the accessibility of the findings from that research to people who are just going about their daily lives, who aren't actually involved in research themselves. So we felt like lived experience research had the potential to be helpful, but it clearly wasn't getting out to people directly. And so that's what sort of started us off on this research project. So of course the first thing we did was to look at the literature. But we pretty much came up a total blank there. We couldn't find any research about consumers' direct use of or knowledge about lived experience research. So we didn't know how useful it was likely to be. I'll leave it there for now. So we didn't know how useful it was likely to be for them. So we wanted to know how we could bring it to people's attention. So the next thing we did was consult with consumers, obviously. So we had consumers on our research team, but they were consumers who were already involved in research, so we needed to look a bit more broadly. And we started off by, of course, explaining to people, well, what is this thing called lived experience research? And what people told us was that they really did value hearing about other people's lived experiences, and that they thought that lived experience research would be really helpful. They thought that it could help people to feel less alone, normalise their experiences, and allow them to learn from other people's experiences. And some people said it was about reframing experiences in a different and helpful way, and especially in non-medical types of ways. Other people talked about finding hope and inspiration, clarifying their own experiences, and better understanding people whose experiences were very different to their own. But our consumer consultants also told us that they saw a bunch of barriers to benefiting from lived experience research. So like we thought, they said most people don't even know it exists. They said it doesn't fall into your lap. It's actually quite hard to find, especially given the plethora of information, good and bad, out there on the internet, and the fact that, of course, not everybody can even access the internet. And lastly, they thought that the research was often in inaccessible format. So, of course, a lot of research that's done is behind paywalls, so you have to pay to access it. But also, it tends to be written in a way that's inaccessible. So it's very long. It's quite boring and academic in the way that it's done. So we decided that we wanted to change that. We wanted to make lived experience research accessible to everybody. But before we went too far, we really needed to find out whether it was really going to be useful to people. So we thought it would, but we wanted evidence. So that's when we decided to do some research, and we're fortunate enough to get the funding from OneDoor to do that. So in the research, we planned to develop some user-friendly and attractive resources to let people know about the findings of lived experience research, to present those resources to a sample of consumers, and we thought that peer workers would be the perfect people to do that, to be our advocates for lived experience research and introduce people to that. And lastly, to evaluate how useful consumers actually found that to be. So to get us started, we wanted to find out, okay, well, what areas of lived experience research are people actually going to be most interested in finding out about? So we had discussions with peer workers, other consumers. We looked at the topics and issues that peer workers tended to talk to their clients about most. And we specifically searched for lived experience research on those topics that we found. And we also gathered together a whole lot of lived experience research that we on the team kind of knew about. And of course, it's not entirely obvious because not all lived experience research has a big sign on it saying there's a lived experience researcher in here. Sometimes it's not actually mentioned. But we all knew people who were doing that research. And for example, one of our team, Kate Gill, is chair of the Consumer-Led Research Network. So we knew people doing the research, and we brought together that lived experience research that we could find. And we also asked consumers for feedback about the topics and articles that we were thinking about, via our Facebook page. So we developed a bunch of criteria for the pieces of research that we thought would be best to translate into our resources. So first of all, they had to be research papers, not individual stories or opinions. They had to have a person with lived experience as an author, and they had to relate to a topic that was identified as being of interest. And of course, we really wanted the findings to be useful to people in their everyday lives, and that was a really important criteria. So we wanted them to contain information that they could use, so strategies that they might choose to try, or different ways of thinking about things in helpful ways. Actually that was there was probably less of that research than what we expected. When we looked closely, a lot of the lived experience research was really about talking to health professionals. So it was about letting professionals and systems know what needed to be changed, what you guys need to do differently. And that research is really, really important. But I think if our research shows that people do engage with lived experience research and it's important, it'll be a good argument for funding more lived experience research that actually does focus on speaking directly to consumers. So we did find a range of research papers on topics that people thought were relevant and that we decided would be good to translate into resources. So in the research that we're going to be doing, people are going to be introduced to 4 researchers, and we're developing 8 altogether because we want people to be able to have a choice. So they'll be shown these are the topics and they'll choose 4 of them, the 4 that they're most interested in. So we also needed, of course, to generate ideas for creative and accessible ways to present this research, and that was really the crux of it. So we held a workshop, first of all, at the Thames conference, and later on a design lab, which was led by Helen Glover, who some of you may know of, and she's got a lot of experience with leading these sorts of design experiences. And those included the research team, peer workers, other consumers, and also our design students from UTS, who I'll talk a bit more about in a minute. So at these events, we used a design thinking process, and to come up with and we used a bunch of creative activities as well to get people really thinking creatively to come up with innovative ideas about ways that lived experience research can be meaningful and can be engaging to consumers, and what those might look like. And in the design lab, we actually started to prototype some of those. Okay, so then the designs that we came up with in that, we handed over to the design students from UTS. So these students are part of an industry innovation, they're doing it as part of an industry innovation project for their Bachelor of Creative Intelligence and Innovation, which I think you'll agree is a very impressive sounding degree. So the idea was that the students would take the ideas that we'd already had and then develop them into, use their own ideas as well, and then consult with the research team and the peer workers, and really who were going to introduce the peer workers were going to introduce the resources to the participants, and really come up with some actual products that we could use. So in a minute I'm going to hand you over to these 2 students, and sorry I'm running 1 minute late, so sorry about that guys. Bailey and Angus, and they're going to talk to you about what they've done so far. But I'll just give you a very quick glimpse of the actual what's going to happen next. So once we're happy with the resources, we're going to be testing them out using an experimental design. So we've employed 7 peer workers from South Eastern Sydney Local Health District who are going to be our research assistants, and they're going to be introducing they're going to be introducing the resources to their clients, and they're going to be evaluating the usefulness of those resources. So they're my contact details, and I'm going to hand you over to our students who are going to tell you a little bit about the resources. And I think did you have a mic, Bailey?
I think you'll be fine.
Good afternoon to you all. Thank you for letting us come here today to sort of share our process and who we are. So my name is Angus Armstrong, and my partner here is Bailey Tinzer. So we're currently in our 4th year of a degree called a Bachelor in Creative Intelligence and Innovation. For the first year, we didn't really know what that meant. It was a grand title, as Anne said. But the primary function of this degree is to introduce transdisciplinarity into degrees that would otherwise remain isolated. So it's the amalgamation of different schools of thought in order to develop a student's ability to solve a wide array of business and worldly problems. We largely embrace the problem space and delve into a diverse range of methodologies in order to understand said problem's context. So we were introduced to the mental health context, and we basically spent the better half of the first 4 weeks understanding that space. We want to understand the politics, the economics, the cultural elements of that space, to basically understand that we're going to move into a solution state with the best tools and knowledge we can. 4th year has also offered us the opportunity to work alongside an industry partner, and upon which our group was met with the Stellar Group's wicked problem. How can we use innovative creative strategies to communicate evidence-based knowledge in healthcare to a wide variety of stakeholders? So here we begin. Like most, our first desire is to understand the brief, the wicked problem that our partner faces. We use a multitude of different methods in order to engage with and widen our scope as much as possible. It is vital for us that we understand the interplay between as many factors as possible before we step into solution states. For this project, however, as Anne has highlighted, we are entering a somewhat uncertain territory. Lived experience research dissemination has not been properly trialled before, and even in the academic sphere, it is only now just developing as a form of mainstream academic inquiry. Therefore, our role as innovation consultants can be rather difficult. And one thing we have really struggled with is the process, along this process has been the thin line from crossing between dissemination into intervention. Our function is not to dictate movements of consumers or peer workers, it is to create a medium or mode of dissemination that is both visually appealing and authentic to the academic articles that they are attempting to translate. Our solutions need to be versatile across 9 service units in the southeastern Sydney Health Districts, as well as being taken outside care units to patients in the community. From the 8 articles selected by the research team, we would need to develop a unique translation for each that could be implemented into the 4-week trial. So today, Bailey and I would like to share some of these with you. I think we've got 3 all up out of 6 that we're doing. So the first solution was a simple podcast for an article titled Recovery from Schizophrenia, a Consumer Perspective, published by Dr. Barbara Tooth and Helen Glover. This article covers the perceptions of what recovery is like in mental health and what assisted patients in their journey to better health. Both Barbara and Helen were able to attend a 40-minute session in which our group had prepared a number of questions that would transform the academic contents of the article into a conversational format. This session's recording will be broken into smaller, more digestible segments for consumers to understand the universal elements of recovery. And our group felt that this translation would be more authentic if the publishers were given a platform beyond academic formats to explain their thoughts and concepts in these articles. Our goal here is not to put just a pretty red ribbon on an article, it is to sort of disseminate and make it easier for consumers to digest, especially when a lot of these consumers can be in quite critical states of mental health. A secondary idea translates an article titled Mental Health Consumer Experiences and Strategies When Seeking Physical Health Care. This article focuses on the experiences of people living with mental health illnesses in health services and certain strategies that can be utilised to improve both their mental and physical health. For this, we wanted to devise a sort of guide that would assist users in their journey through mental health services. So we have developed a pack of cards that includes quotes, comments, and successful strategies from other consumers of mental health who have gone through service systems from the article, arranged to give the user insights and inspiration when they are looking to improve their mental and physical health. Simplicity and direct translation have been key to our designs, ensuring that we do not convolute the article. As I said earlier, these designs and other ideas will be available at our table later, and we would welcome any input from anyone curious about our process. And Bailey will introduce one of his prototypes now.
So hi, I'm Bailey. I'm a student, PCI student.
David,
from
you can't hear
So I'm another student from the... I'll just stand. I just like walking around, so it's a bit of a, so yeah, I'm also from the Faculty of Transdisciplinary Innovation here at ETS. And before I introduce another resource, I just want to highlight the term prototype and what exactly do we mean by that, because a lot of people when I discuss prototypes, they seem to think of like a high-tech piece of equipment developed in Silicon Valley or something. But it's essentially what prototyping is actually a means in which we can convey an idea without spending too many resources, time and money. And so this brings me to another idea we're working on. It is the personal medicine pack. This prototype was developed for the Importance of Personal Medicine journal article written by Patricia Deegan. This study was written to explore how consumers use their personal strengths and resources rather than just pharmaceutical medication for recovery. Consumers challenged the idea of pill medication as a cure-all and spontaneously highlighted how personal medicine can help well-being management. Personal medicine could be anything from going for a walk to solving a math problem. And the personal medicine pack is a nice little guide in finding your own personal medicine and learning about that concept. We've used the typical Webster pack as an icon to reinforce the idea that these activities that you do are in fact valid forms of medication. Rather than just taking pill medication each day, this personal medicine pack provides an opportunity to learn about personal medicine from others with lived experience and then build your own regime. This is one of 6 resources we are working on, and if you want to learn more, just come down and have a chat. We're just at a booth around the corner there. Thank you.
And can I just say, so our students they're mid-development of the resources, so they've got a table just out there. So if you want to go over and they can explain to you and tell you a little bit more about what they're doing, and then you can give them some feedback, because they're always looking for, you know, feedback from, especially from consumers, but other people too, like what you might think of those resources and how they might be improved or anything like that. So go and have a chat to them.
Thanks, guys. Prototyping is always the best way forward in a very much needed area, so thank you very much for your time and your talk just then. We're going to keep the agenda moving fairly swiftly. I'd like to introduce Tony Stevenson, the CEO for the Peak Body for Mental Illness Fellowship of Australia, to launch this year's National Schizophrenia Awareness Week. Tony commenced as CEO for MIFA in December 2016. Tony has worked in the mental health and community services sector for over 35 years, alongside families and individuals, to inspire self-confidence, self-determination and hope. He has held many CEO-level positions with some of Australia's most well-known not-for-profits, as well as a long history working in executive roles in both Commonwealth and state governments. We are very honoured to have him here to launch the campaign today. Thank you.
Thank you very much, Mitch, and I pay my respects to the Gadigal people of the Aurora Nation, who continue to be the owners of the land on which we meet still today. Congratulations to Kathy and Anthony for putting on such an amazing symposium today, and thoroughly enjoyed all of the speakers. Last night I did something which is fairly extraordinary. I celebrated my birthday. I had dinner with my partner and my 3 children and some friends. After dinner I went home. I actually flew in from Brisbane this morning, but last night I watched the end of the Brisbane Broncos and Sydney City Roosters game, and obviously very happy with the outcome. But on the whole, you might think a very extraordinary night of having dinner with my children and seeing a Queensland team beat a New South Wales team. Yes. that's certainly one way to build, yes, exactly, and inspire. But actually, it wasn't commonplace for me. I have 3 children, including my daughter, who has lived for over 20 years with mental illness. So for us, at times, probably 2 or 3 times a year, we don't know whether she will survive the night. Many times when she's been rushed to hospital by ambulance, where police have had to intervene and restrain her, times when she has been in acute mental health facilities, and times when she has booked herself into a private mental health facility for respite and support. And throughout that period of time, she's had relationships, she's lost relationships, she's held down jobs, she's working now, she's studying for a Masters in Social Work. She's working as a youth worker with adolescents and young people with drug and alcohol addictions. And through the support that she's had from her professional team, psychiatrists, psychologists and a GP, who have been absolutely her bedrock in many ways for many, many years, and a very supportive work environment, but of course her family and friends. So I was very pleased to have such a wonderful evening celebrating my birthday last night. I wanted to talk about Schizophrenia Awareness Week this morning, and that's, okay, oh here it is, sorry, I think I'm fine. Thank you. So I wanted to share with you a national launch this morning for Schizophrenia Awareness Week. The Mental Illness Fellowship of Australia is a federation of organisations, and One Door is a founding member of the Mental Illness Fellowship of Australia. We have 7 organisations as part of our membership, organisations which have followed the same story as One Door. 35 years ago, when people, particularly people living with schizophrenia, who were reunited with their families, the challenges that existed at the time, and the need for organisations to bring families and people together to support each other and to advocate to government about the services that were needed to support people who are now living back in the community. In Queensland, we have Selectability in North Queensland, Bridges in Central Queensland, One Door, of course, in New South Wales, the Mental Health Foundation at the ACT, Skylight Mental Health Services in South Australia, Mental Illness Fellowship of Western Australia, and MIFA NT. 7 organisations operating across 80 communities around Australia, supporting about 20,000 people annually, people living with mental illness and their families and carers. And I'm sure you already appreciate this because of your strong connections with One Door. But 60% of MIFA's member organisations, our teams, our boards, 60% have lived experience. And we continue to provide specialist, place-based community building programs with a strong focus on recovery and lived experience. And we've already heard this morning some of the challenges around the mental health system and what we need to do to improve that. And that's what MIFA does. We amplify the voice of lived experience that comes through One Door over 35 years and all of our other member organisations to provide a voice into government about what needs to change and what needs to improve about mental health services. One of the things that we do every year is try and raise awareness, particularly about schizophrenia, and to break down the stigma and discrimination that still exists. When we think about how our community knows about and responds to serious illness, I think even to look at a couple of examples, such as cancer or heart disease, for example, where people's lives are touched, they take time to understand what's happening for that person, how they can help, what can they do to support them. They're very interested in their recovery. And we know that there are many, many forms of cancer, and we're probably aware of a lot of those. How many fun runs are held every weekend to raise money for cancer or heart disease? How many heads are shaved? We have the pink test at the Sydney Cricket Ground every year. Where do we see the evidence of people getting behind the other serious and severe illness of mental illness? If it wasn't for One Door's walk across the Harbour Bridge every year, I don't think we would have any visible experience of that at all in Australia. So what we want to do in Schizophrenia Awareness Week is to talk to communities right across Australia and dispel the myths, raise the awareness, talk about schizophrenia, and most importantly, talk about recovery. We have the opportunity through strong media exposure. So already before the week even begins, I've had about 50 radio interviews from Cairns to Hobart, from Perth to Byron Bay, right across Australia. We have a media person who helps us get coverage, which I think by the end of next week we will cover the whole of Australia. Indigenous radio stations, ethnic broadcasters. It's so important that we're able to change some of the myths that exist around schizophrenia, because people rely on the myths and the stereotypes that have been around for decades, if not longer, centuries. They feel that somebody who has schizophrenia is somebody to be feared, to be avoided, that if families, God forbid, have somebody in their family with cancer, they're very sympathetic, want to know how to help. But does that happen for families that have a loved one living with schizophrenia? I don't think it does. And I certainly feel privileged when somebody who I know asks me, how's my daughter going? I don't think it happens often enough. So we need to talk to the Australian community to help them understand about a serious illness that exists in their community, and to ask people to take a far more mature approach to understanding what people experience, to be able to talk about serious mental illness, severe mental illness, openly in their families, in their community, their neighbourhoods, their workplaces. Because while people feel the stigma, it's not easy to talk about it. If you can't talk about it, how do you find out where to go to get help? The stigma actually prevents people from getting help, and because of that, their quality of life suffers considerably. So we've got this opportunity to talk to the Australian community. We'll have radio, some television interviews, we'll have social media, and we'll have far more of that happening next week. I'd like to start with setting the scene. There are 230,000 people in Australia living with schizophrenia, about 1 in 100. And when you consider families that are connected, that's over 1 million people affected around Australia. And less than 50% of people with schizophrenia are getting the help that they need. And that includes treatment from mental health professionals, but it also includes recovery support from experienced community organisations like One Door. Would we as an Australian community accept that only 50% or less of people with cancer or heart disease were getting the treatment that is available? And would we find that it was acceptable to, in a way, not intentionally, but perhaps to make people feel as though they may not deserve that help? But somehow I've been a bad parent, and that's why my daughter has a severe mental illness. Life expectancy for a person with schizophrenia is just 54 years of age. Again, in Australia in 2019, it is absolutely unacceptable that that is happening to a group of people in our community. High result of suicide, undiagnosed and untreated physical illnesses, a whole range of physical factors that contribute, along with suicide, to a low life expectancy. 12 times the rate of suicide for people living with schizophrenia. People don't realise, I think, on the whole, that schizophrenia can happen within any family. It happens to 1 in 100 families. Families are never prepared for that to happen to them. I think that's fair to say that that's the case for any serious illness, of course. But families don't know where to turn to, because they often don't know how to talk about these issues. And sometimes the behaviours and how their son or daughter's mental illness is expressed at that time, late adolescence, early adulthood, perhaps they think there are far more sinister factors at work, and there is a sense of shame associated with that. I think that is a sobering thought for many people to understand that. Yes, there may be some early warning signs of schizophrenia, but I think it's fair to say that it takes some time to find out the diagnosis, to find out the sort of treatment that's available and what works and what the person decides to do for themselves in their own life. But the message that we take out to the community during Schizophrenia Awareness Week is that we all need to be mindful of our mental health at all times, for ourselves, for those in our families, in our neighbourhoods, in our workplaces, to help people reflect, I guess, on those warning signs. Sleeplessness, a lack of concentration at work or at school, becoming more withdrawn, isolated from your family and from your friends. That we want the Australian community to really think about the importance of their mental health and to take action either for themselves or for others that they're close to seek help and to get the support that is available. And certainly to finish with a very positive note about the potential for recovery of a quality of life in your own community, with your own family, that is possible for people living with schizophrenia if we break down the stigma, if we accept schizophrenia as a very serious illness that exists in our community, if we encourage people to seek help, if we support people, if we're interested in their recovery, interested in how they're going, and just return to a relationship of respect and acceptance that they have with that person. So today, at the One Door Symposium, this is the official national launch of Schizophrenia Awareness Week. So I wish to thank Anthony and Kathy for the opportunity to launch Schizophrenia Awareness Week this year. And I hope that the media campaign touches you at some point in time, I'd love to hear your feedback about that. I've had a number of interviews already for Sydney radio stations which have been recorded and which will be broadcast starting from Monday morning. I'd love your feedback about the messages, how we can resonate a call to action within the Australian community, and hope with you that we're able to break down the stereotypes and the stigma that exists, encourage people to seek out support, and we hope together that people can live a good life with their family and their community. Thank you very much.
Thank you, Tony. Wow, what an amazing event, what an amazing awareness week. I'm really glad that we're all here at the official launch now. So there'll be some engagement outside after this, later this afternoon, to be involved more so in that, along with Lucid Broadband. So thank you very much, Tony, as well for sharing your personal lived experience. We're going to have a few questions before we go to our next break. Jason had to shoot off to the airport, but Justin, Emma, Sarah and Tony are still here. And so I'm going to ask Jamie Lee just to rove with the mic, and people can fire questions as needed. We've got one here. Jamie?
I hate to be flippant, Tony, but how can we get Clive Palmer interested in your launch?
Is Clive Palmer interested in anything else except Clive Palmer? Great question, thank you.
Hi, this one's for Tony. So with Schizophrenia Awareness Week, I think it's a really great initiative. I do work within a psychosis program for young people. I guess my question is, in terms of psychosis doesn't just appear within schizophrenia. There are many different types of psychosis. Do those also get raised in this kind of week?
As well as we can, because some of these messages are perhaps quite complex. We don't have a lot of time to get the message through. We're in the order of ignorance to those terms, you know, and also in terms of the visibility and particularly the popular culture implications. I think schizophrenia is a word that, for some people, it even goes as far as instilling fear in people. And so perhaps, you know, we have to start somewhere. And I think that without trying to broaden the subject or make it too complex, that we can bring in those other messages. And I often do refer to psychosis if I think I'm, you know, talking too much about the same topic, and just broaden it out a bit. But I think your comment is very valid.
Hi there. My name is Michael. I want to say how much I've appreciated all the talks today, but I want to identify one significant gap that perhaps can be picked up at the next seminar conference. That gap is the big picture. Everything that we've heard today has looked at some specific little part of the system. It was fantastic to have that display of all the organizations we did initially and just show you how complex it is. But everybody talks about the lack of funding. You're not going to get funding unless you actually address the big picture stuff. Now, I'm a retired career public servant. I have worked in central offices of most of the departments. The last 20 years of that of health. I've developed programs and services and so on. And I can tell you, we're not doing it the right way. we're not actually looking at how decisions are made within the system, who gets funding and why, and how they pursue their goals of getting that funding. So, for me, looking at it from the other way, there are two big barriers. They're structural and they're financial. They're linked, but in order to link them and to progress the whole thing, you actually have to address the big picture stuff. So maybe next time we can spend a bit of time and effort to address that. Thank you.
I absolutely agree with you, and we will have a panel discussion later with a few of the commissioners and Dr. Stephen King, and it is called Do It Better or Do It Differently. So it's your time to shine.
Hi, my question might actually tap into that, a bit of that conversation. I'm really excited to hear about the CAT research, and I'm really excited to hear about Wondor funding that, because I'm a Wondor worker and it's all good. But what really pricked my attention with the CAT is that there are so many chronic illnesses that for various reasons, whether it be long-term deterioration such as with multiple sclerosis or even with epilepsy, and certainly with treatments such as with rheumatoid arthritis and with cancer, that brings on cognitive deterioration or at least changes, and they could just really benefit from some sort of research like what was just like, it's talked about today. I'm just wondering, is there any approach in those directions that might actually bolster the funding, the tapping in part? And
I'm going to hand the microphone to Justin.
It's just exciting, that's all. And I want to see it like explode. Yes.
Me too. I guess from my perspective, there are. I think there is broad applicability to the application of compensatory approaches when it comes to cognitive difficulties. I think that the themes and the approaches will probably be similar across different kind of conditions. I do think that the pattern of difficulties and the types of difficulties that emerge in different contexts might vary, and so this is this is certainly one approach that's really useful. I can't say that I'm across all of the other research areas, but I do think that there's certainly broad applicability. It's very, like, one of the things that attracts me about this kind of approach is that it's just real. It's in people's houses doing the things that they want to do and supporting that. That's why it's attractive to me, and that's why I think it can engage people really effectively, because it's about what they want to do. So yeah, and I certainly would love to see it spread across into other areas as well.
Thank you. Nick Baines, Swansea Greenlight. As you know, as you're all aware in this room, we've both had the enjoyment of a state election and now a national election. And it seemed to me quite obviously that a lot of organisations have prepared for that and worked out an agenda for raising awareness of their particular subject and get more funding. I felt very frustrated that I didn't find anything hardly at all about mental health. So in frustration I thought, well, I'll phone up my local candidate and see when he was going to hold a general meeting. Well, he wasn't going to hold one. I was advised I'd go to Thornley railway station between 6 and 8:30 and perhaps have a chat with him. So I just wondered if there's any organisation that actually prepares for these elections and tries to get funding or raise awareness, or like we're doing for schizophrenic awareness. Thank you.
Yes, there are many, and including LIFA and Headspace and others here today. One of the decisions that we have made as a sector is that we do need to identify the one or two most important issues in an election campaign or a budget context. Because, you know, one of the problems for our sector could be that we just come with so many different fragmented issues for government. So we and Headspace and others also belong to Mental Health Australia, which is the national peak body for mental health. And through that process, we are working on what would be those one or two issues. Now, one of those is a complete rethink of support for people with severe mental illness. That message has gone to the Productivity Commission, and the Commissioner will be here this afternoon to respond to that. I think we hear so much about mental health during an election campaign or a budgetary process, but it is fairly fragmented. So there might be more for suicide prevention or Indigenous suicide prevention, which came through in this campaign. Additional funds for some organisations like Headspace, Beyond Blue. And sometimes governments feel as though they've done their job when they've listened to some of those voices. So it is time to really focus in on the one or two most important issues, so we all have to agree on that for a start. And that's the way in which we have responded to the Productivity Commission's review or inquiry that's happening now. And part of that is a complete restructure of the mental health system to bring it together to work on the bigger picture, as the gentleman said.
I just have a question up here from Simone.
Hi, thanks. My name's Simone. I'm someone that's come full circle and a strong believer that you can't rely on medication to do everything. You actually have to go the extra mile, and I remember the days when I couldn't even dress myself. So I'm happy, and I really would like to talk further after lunch with the prototype of that you mentioned, you know, life beyond medication, and you can't rely on it for everything. Yeah, it's just, I have gone that extra mile, and I have gone full circle from someone who was completely oxymoron, but also having been disabled by medications.
Yes.
And I don't expect to take a mental health medication and end up with physical disabilities. And I've had to start from very basic living skills to what I do now is, you know, completely much more normalised. Yeah. Thanks. It's not a question.
We'll go 1, 2, 3, and then I think we're done, yeah? This session.
Hi, my name's Kelly Forster. I'm from regional New South Wales in Griffith. It's near Wagga, about 200 kilometres away. But most older people know Griffith for all the wrong reasons, but it is a nice place to visit. Good food, good coffee. I have had 23 years of lived experience as a carer for my brother, who started to get ill when he was 16. He's 39 now and has a diagnosis of paranoid schizophrenia. Looking at all the Schizophrenia Awareness Week, I do agree that yes, there is a stigma surrounding that. I've watched my brother sort of evolve into 4 different people over those 23 years. And it is, as a carer, I think we go through this continual grief of seeing that, and also a sense of real loss of what his life could be. It's a hard road, and it's a roller coaster, I guess. And for many carers in the room, they'd understand what I mean by that. I just wanted to talk about the subacute care and crisis point, especially in the country. I feel that there is a huge gap and that's where the system is broken. In my brother's case, he had 4 hospitalisations to the Wagga mental health unit, which is a wonderful unit and great staff, but the system on the ground let him down. And during his last hospitalisation, because he's had his diagnosis for 21 years, his last hospitalisation took them 5 months to get him back into the hospital. Because of that, and because he was in crisis point for so long, and in the throes of an episode, he's no longer able to get back to where he was. So he was working 2 part-time jobs. He was studying a university degree, living on his own. He was high functioning, but he was in one in 3 that it was debilitating. He did struggle, but he's the strongest person that I know, and I've learnt the most from him in my life. He only has us, his family, as his support, but I think yet the stigma needs to be broken down. I went to a course talking about the disabilities of physical illness compared to mental illness, and we had to do a short exercise, and even though I know my brother for so long, this slapped me in the face. The disability, the highest disability of the physical illnesses in that room was chronic emphysema, so being attached to your oxygen tank 24/7, and metastatic breast cancer. And of the mental illnesses, the 2 that slotted in right side by side was paranoid schizophrenia and post-traumatic stress disorder. Now, my son was diagnosed with complex post-traumatic stress disorder last year after he was abused by a fellow student at school over a 3-year period. Stigma comes in many forms, and I think it comes through victim blaming, victim shaming, myths. But I think if you can do a visual cue like that, it hits people in the face, because it's not as bad as a bad back or epilepsy or these mental illnesses. They debilitate people, and the carers are left to pick them up, to hold them, to give them that safe place to fall. And without us and the carers in the communities, they would be left isolated, and in many cases I think the social connectedness is what gets them through. I think prevention is better than cure through education, and I agree that the mental health system is broken, and I don't think it will ever get any better unless mental health is treated like an aggressive form of cancer. They're just too slow to act. But thank you for listening to me.
I saw a lot of head nodding during that. Yes, and thank you for sharing your own experience as well.
My name is Ethel. I belong to the Beautiful Minds Committee. And thank you. Yeah, you were talking about Parliament and that. When we have a function to raise funds, we raise funds for mental health. That's who we are. Just pure voluntary fundraisers. And we've done a lot to help Bankstown Hospital. There has nothing been done to that since 1979. Right. It was a disgrace. Anyway, things are moving. And we raise funds to put classes in there for patients, art classes, music, gym classes. That's what we do. Anyway, the thing about it is when we have functions, we actually ask the members of Parliament to come to our functions, the councillors to come to our functions, so that they really see what we're doing and they do take a little bit of part in it. But, you know, I and myself have suffered mental illness. I had 27 years in and out of hospital. Once I was locked up for 18 months, roughly. But for 25 years, I've got into natural therapies and I have not been sick since. And no medication. But that's just me. Not telling you, but that's just me, right? Okay. So, you know, I think that the way you kind of get it known. And see, you said too that schizophrenia frighten people. Well, schizophrenia people, I'm sorry, but I think we frighten them because they can read us. They really see who we really are, right? They're above here, and we can't get up to them, so we medicate and push them down, right? To come down to us, yeah? Yeah. Now next, oh wait, I won't advertise, I'll put some papers out there later. We're having a big function in July. I'll just leave a few bits and pieces out there for you. Likely to advertise, but I just kind of think that we need to put our heart and soul in it, even get placards and get down the street. I don't know, this NDIS is such a mess. We have a place, Harmony House up at Bradbury, and I can't see, I really can't see how these people have been coming there. We've had that place for 10 years, right? And anyone with any kind of mental illness can come there daily. But NDIS is now saying, no, only those on packages can come.
Thank you for that reflection. And I'm glad you're feeling strong and have been for so long. Okay, last question, and then we're off to the break.
Thank you. Good afternoon, everyone. My name is Peter. I'm a retired GP from Wagga. I happen to be on the board of Sunflower House, which is a clubhouse model of taking care of Friends of Sunflower House in Wagga. Two of our speakers have alluded to primary health networks. In my earlier days as a GP, I was a founding member of what was the forerunner of the primary health network in Wagga. Primary health networks now are one of the major ways that the Commonwealth Government funds mental health and many other programs. My question is, of both of Jason, who mentioned it, and of Kathy, who mentioned it, how effective are primary health networks and who evaluates what they are doing and what control or lack of effectiveness they have? It's a loaded question.
Thanks, Peter. We have some primary health network people here, and it's lovely that they're here. I think what it says for this primary health network is that they're interested to hear the voice of everyone here. And I think that what the federal government and through Jason talked about through the National Mental Health Commission's review of how mental health funding was being funded, I guess all the services, was there needed to be a local and regional plan. And so that's what the primary health networks are there to do, is to tap into the community, tap into all of us living in our own houses, units, and go, right, where's the best bang for the buck, and how do we do this in an integrated fashion? Now, the primary health networks, I think, are very new, and they're learning. I think what we've got at the moment is we've got the NDIS being very new and learning. We've got primary health networks new and learning. And in amongst that is this, I guess, journey along and the consequence of that, which is what we're seeing. But there are some great initiatives coming through it, you know. So we run Hospital at Home, which is funded through the primary health networks, which is a peer-run service helping people come out of psychiatric units. There are an immense amount of great programs. Our primary integrated care service, which is called PICS in southern eastern Sydney, which we've got a collaborative nurses and peer workers, is funded by the primary health network. So there's some headspaces that are funded by primary health networks. So I think there's some really great things that are being funded by primary health networks. I think they've also been given the wrong end of the deal and this whole bit around transitional funds is also a challenge they have to take up, which has been decisions made from the Department of Health, which is so removed. So I think that there's a lot of work to be done, and I think from my end, and I think from Tony's end, what we want to do is hear your voice to help the primary health networks in their job, to also influence those in Canberra who are making these decisions. I think it's along the journey. I just think we've got a little way to go, but I think it is about relationships and about enabling systems to help the right voices be heard in the right ears. Does that make sense? Yeah.
Well said.
Yeah.
All right, that wraps us this session. So 1:45, can we please be back sharp for our